Hi, this is Dr. Stanislav Henkin, General Cardiology Fellow at Dartmouth-Hitchcock Medical Center, and today I have with me two experts in peripheral intervention, Dr. Sahil Parikh, Associate Professor of Medicine at UAMC, and Dr. Herb Aronow, Director of the Cath Lab at Brown. Thanks for having me here.
My pleasure.
So I'll pose this question to both of you. First of all, how did you get interested in peripheral intervention besides coronary intervention?
Go ahead, Herb. I think I'm sort of a testament to you should try everything, because as a cardiology fellow, I had zero interest in vascular disease, and I tried to keep my mind open. I decided, well, I'll give it a try, and as an interventional fellow, when I started doing vascular intervention, I fell in love with it, and I've never looked back. So I think everybody should try it. Sahil, maybe you knew when you came out of the womb that you were going to be a vascular interventionalist.
No, on the other hand, I knew I loved interventional cardiology, but I was really interested in the technology and the innovations in the space. And as I was training, I was clearly more interested in atherosclerotic vascular disease, for example, than other kinds of valvular heart disease and so on. So I got interested in the new technologies and the clinical innovations in that area. And I was mentored by a lot of people who were working in that kind of research, both preclinical and clinical. And so that synergy is really what got me interested in vascular intervention. And then frankly, when I started doing the cases, I found them to be really creative and interesting. There's many ways to get access, many ways to perform the intervention. And there was always an obligatory longitudinal relationship with the patient. And so it was more like what I was familiar with cardiology. And so I found that having that long-term relationship with patients and providing their care, both for their coronary and extracoronary vascular disease, was a really good fit.
Interventional cardiology is a one-year fellowship right now, and at some high-volume centers, there's a lot of peripheral interventions as well. Do you think that an interventional cardiology fellow needs extra time and additional year in addition to coronary intervention to truly learn peripheral intervention?
Thank you. I think that if you're going to dedicate a good part or even all of what you do professionally to vascular disease and treating vascular disease, I don't think you can do it well without doing another year. I think there's too much. The field's evolved, and now it's not just on the arterial side, it's on the venous side. Everything from acute limb ischemia to treating CLI, pedal access, all these fairly high-end and complex approaches to these patients that require time and training and repetition. I don't think you could see that kind of volume in an average program in the context of a year, and also at the same time master everything you need to in the coronary realm. So I would advocate for an additional year.
Yeah, I totally agree with Herb. I think that there's no substitute for spending the time in doing both the procedural care, but also the cognitive things that you need to know to take care of the patients. For example, there's a lot to understanding the non-invasive vascular laboratory, and I think most cardiology fellows don't get a lot of experience with that during their general cardiology fellowship. There's a lot about taking care of wounds and understanding the pathophysiology of venous disease, for example, that's not commonly covered in cardiology fellowship. So there's that cognitive part of it, and then there's no substitute for doing the cases and having the experience and the mentorship. So I think that it's really important for cardiology fellows that are interested in vascular intervention to sort of know that ahead of time, get those cognitive parts as and when they can during their general cardiology fellowship, get their core interventional coronary training so that they're competent at that and really expert, and then try to get advanced training in vascular intervention. And I think that's difficult, but increasingly is going to be the standard that we're going to be held to.
I want to piggyback on what Sahil just said about the part of your practice or your training that's outside of the lab, because if you think about the number of patients you'd need to see that might culminate in someone needing an intervention, it's the minority, right? It might be 1 in 5, for example. So you have to be really good at seeing the other 4, evaluating them, doing their non-invasive testing and everything else, and that's all time spent out of the lab.
How do you share the space with interventional radiologists and vascular surgeons? What makes you different as an interventional cardiologist who's doing peripheral intervention?
Well, I think that it's a lot about what we've been talking about. Is that as the vascular specialist in my program, for example, I take care of patients longitudinally, and I provide their coronary and general cardiology care as well as their vascular medicine and intervention care. And so for me, I think the way you distinguish yourself as a cardiologist is that you take care of the patient longitudinally and provide that care. And we work very closely with interventional radiology and vascular surgery, just as we do with cardiac surgeons with our coronary care. And so I think that the paradigm isn't very different. It just requires that you recognize that as the cardiologist, you're still a medicine subspecialist who still takes care of the patient as their physician.
I've worked in a number of hospitals over my career, and every hospital seems to have its own culture, if you will, as far as whose domain. I mean, I hate to use that term. It's not my term.
Yeah.
I don't really like it, but who should be seeing these patients? And frankly, anyone with the requisite skill sets should be seeing these patients. And you might be at an institution where there are surgeons who only do surgery. Maybe they're not doing endovascular, or maybe the interventional radiologists are doing a whole lot of endovascular, or maybe neither are. Whatever it is, you can fill that gap. But I think the most important part of that is what you mentioned, Sahil, which is it really needs to be multidisciplinary, and there needs to be collaboration. You need to be able to get everybody in a room working together who agree on requirements for privileges. They shouldn't be any different for an endovascular surgeon than an endovascular cardiologist. But it's important, I think, to work together. And then the rest of it is building your practice, right? You hope that people, if all three specialties offer the same services or similar services, then you just have to do, as you always do, a really good job at building your practice and building referrals.
Any final advice for general cardiology fellows who may be interested in peripheral intervention?
I think we've talked about most of the things, but I would get as much of the cognitive knowledge as you can as a general cardiology fellow, and seek out mentorship amongst your fellowship program or even outside your fellowship program of doctors who are committed to taking care of the vascular patient.
I would just add to that outside of training programs, there's some terrific conferences. The ACC has just a whole host of excellent peripheral vascular content. There are other societies that do as well. So SCI also does. There's a dedicated peripheral track at their main meeting. There's also the Fall Fellows course that tends to have a lot of vascular content in it. And then the Society for Vascular Medicine also has a great course that focuses not just on the invasive side, but on the non-invasive side. And I think those are all excellent opportunities for conference attendance, not to mention all the online content that's out there as well.
Thank you both so much for speaking with me. For more videos, please visit youtube.com/FITsontheGO.